Hello and welcome. Welcome. I see people signing in. Thank you, thank you, thank you for coming. We're going to get started in just a second. And if you've just signed in, please go ahead and tell us where you are signing in from so we can say hello to you. My name is Dr. Lynae Brayboy. I'm the Chief Medical Officer and co-founder of Ovom Care. And I'm so delighted to have my colleague, Vanessa Guzman from AAS Health. And so we are excited to talk about empowering our communities, especially with data, not just impressions or opinions, but data. And specifically when it comes to reproductive health, because there's a lot of secrecy, there's a lot of stigma, there's a lot of misinformation and biases that prevent certain groups from getting the care that they so desperately want and need. So we are excited to have you all here. Thank you for joining. And I'd love to see where everybody is from. So please put in where you're from. And I'm going to hand it over to my colleague, Vanessa Guzman, to introduce herself and tell us a bit about herself and AAS.
Thank you so much for having me, Lynae. It's such a pleasure to be with you all. Again, my name is Vanessa Guzman. I'm a biomedical engineer by training, and I'm also the CEO and founder of AAS Health, which is a woman coaching-based organization focused on improving the lifestyle and healthcare outcomes of women across the globe. Thank you again for having us. It's going to be a great dialogue, and as we all know, the timing couldn't be more perfect.
Absolutely. And if you're just joining, thank you. Welcome. We are just now starting the webinar, and I'll start off by telling you a little bit about who we are at Ovom Care. So again, this webinar is not meant to replace advice from your healthcare professionals. It's just information. So please keep that in mind. So what is Ovum Care? Well, we're a hybrid IVF clinic, and we leverage AI tools to help improve patient experience and also increase patient chances through IVF and make it financially accessible. We'll be talking a lot about accessibility today. So those are the premises of Ovum Care. And I'm actually coming live to you from Cascais, Portugal, which is right outside of Lisbon. And we are building a flagship clinic here in Portugal. And we're excited to tell you a little bit about Portugal. So this is our medical team. So we have our medical director, Dr. Renato Martins, who's an MD PhD, our clinical director, Dr. Joaquim Nunes, and we also have our senior fertility nurse, Vanda Costa, as well as my colleague, Ahmed, who's also an engineer, like Vanessa, who's also a trained embryologist, and he's our VP of clinic development, and then myself, I'll be visiting very often here in Cascais. So why Portugal? Why did we choose a destination in Europe? Well, one of the reasons is that even though Portugal is an international, cosmopolitan, beautiful, historic place, it's also accessible. And I'll tell you how it's accessible and also affordable. And yet you can get world-class care with my colleagues that I just introduced you to. So it's a wonderful place to come. And having flown many places and lived in many different countries, Portugal is just easy and we love it here. So hopefully you'll come and visit us. We are in Cascais, which is again 20 minutes from the airport. It's not a heavy drive. It's actually a drive I've done a couple times this week. And we are in a nature preserve, and we're about 5 to 10 minute way walk from the beach. And we specifically chose this, actually my colleague Ahmed chose this place because of its location, its beauty that surrounds it, and also the affordability. Even though it's a luxury environment, this is even with travel, hotel, and an IVF cycle, you can spend less than if you go down the street in many, many places around the world. So getting to Lisbon is also very easy. Again, Lisbon is a very accessible capital. You can get to Lisbon from multiple places on the continent, as well as also from the United States. Although South America is not shown here, there's a lot of legs from Brazil, and as well as all throughout the EU. So, and you can see the pricing is actually not expensive. I booked my flight like 3 days before I came here, and it was very, very affordable. So we introduced ourselves at the beginning, but if you're just now joining, I'm Dr. Lynae Brayboy. I'm the co-founder and chief medical officer of Ovom Care, and I have my guest today, Vanessa Guzman from AAS. and health, and we're going to talk a little bit about accessibility and empowering our communities, especially when it comes to reproductive health care. Vanessa, you want to do another re-intro as some people joined right after?
Yes. And welcome everyone who's joining us from all over the country, all over the world. My name is Vanessa Guzman. I'm a biomedical engineer by training. I am also the founder and CEO at Ella is Health, which is a women coaching-based organization that aims to improve the lifestyle and well-being of women across the globe. So thank you again for having us today. And we just appreciate the opportunity to discuss this really important topic. I figured I can't have an honest and authentic conversation without really talking about my authenticity and my roots. I'm a Latina. I am the daughter of Dominican parents. I was born and raised in Brooklyn, New York, in the US. And I call it two mountains. My first mountain was very much focusing on my career, getting to know my core values, and then growing and honing in on that. And I'm now working on my second mountain, which is raising a family of 3 under 3, and also caring for parents who are Spanish speaking only and are above the age of 75 with multiple conditions, including cancer and dementia, which are key drivers of cost, care, and a lot of pain in our culture, in our community. And I'm honing in on what my purpose is at this time. And one of the purpose and the mediums that I'm using as a tool to exercise who I am and raising my voice is really the creation of Ella is Health, which brewed from an unfortunate 3 recurring miscarriages back in 2020, where for the first time at the age of 35, I learned how important it was for me to understand my body and make that mind-body connection, which we often don't see, especially in women of color, but just in communities across. I think that's all relevant to all of us. And when we talk about wanting to close disparities, close gaps in care, especially for women, it requires truly an understanding of where the disparities exist, how they manifested, what was the root of it, and then using women's voices, stories, experiences, design solutions. I really feel that we were designed the way we are individually for a reason, for a purpose. So understanding that and embracing those stories is going to be truly relevant to what the next phase in our lives is going to be. I want to anchor ourselves not only in our stories, but also the financial. Closing the gap in women's health today across the globe accounts to about $1 trillion to improve lives and economies. And it's written for a reason this way, because when you invest in women, you are investing truly in the lives of families, households, children's generation, companies, productivities across. We are natural creators, we are natural groomers, we're natural nurturers. And when you invest in women, you basically you basically invest in creativity and innovation. That's the bottom line. And so I'm going to bring you back to a little bit to roots before we go ahead and display what are the disparities of care and what we can do about it, and then start the conversation from there. Oftentimes, women and races across the globe, we're pinned into we're having chronic conditions, or we're having certain disabilities, or we're having certain disadvantages because of our race. It's truly actually racism that drives health disparities, right? When we're thinking about some of the political and institutional processes that have been instituted for now ages and ages that have social constructs, it has basically determined and created social factors, including environmental factors, that have deconstructed our ability to surface and gain access to Lynae's earlier point, to proper healthcare, to proper investments, to proper strategies to address some of the disparities that we see today, including chemical stressors, individual factors, obviously that's specific to us, but even think about mass incarceration, housing, food access, healthy food access, exercise, lifestyle. We can all say, money doesn't buy happiness, but money does buy convenience. So a lot of the disparities that we see today are very much rooted on a racism and our inability to have the income and social determinants of health factors that perhaps others have better access to.
And I just maybe want to pause here for a second, because maybe some people who've just joined, you said it, and I just want to maybe re-emphasize here, Vanessa, that race is a social construct. It's not biological. However, in medical training, oftentimes around the world, race is not really thought of in that way. And only in the last, I would say, maybe 4 or 5 years, did we start to say that people are not biologically racialized. They're racialized by society, right? So we are all one human race, that's true, but race was only meant to create a hierarchy, and that's all that it is.
Absolutely. So when we use the term social determinants of health, we're referring to the 80% that influences our overall health. 20% is actually biological. 80% is the social contracts that we're referring to. So when we look back and we try and identify what is the root cause, what has determined us to be in this position, in this place where we see Black women dying because they're now pregnant, and there's preterm labor and other factors like diabetes and also all sorts of livelihood issues, right? This is the root of cause of it, and the solution lies in addressing that root cause.
I think that was elegantly said. And I'm going to go to our next slide here.
Sure. And some of the gaps. So the way that I always kind of frame the framework or what's missing in the longitudinal care for women truly is innovation. And innovation is at the very top, right? Think of innovation as the solution, as the nirvana where we want to be. But it's missing key components. It's missing research. It wasn't until like the last, 15 years that women of bearing years were included in key research. Isn't that amazing that we have, it wasn't until like the last 15, 20 years that women between the ages of 25 and 40 were included in a huge majority. Over 700 specific researches were completely missed for that age group. Yeah, so absolutely. Understanding data is going to be key to the success.
It wasn't law in the US until 1993.
Yeah.
Yeah. So we've missed out on understanding how physiology works in women's bodies for too long.
For too long.
Women of all different races and ethnicities.
Correct. So one of the call to actions for all that are listening or those just seeking to understand today is counting women, but counting all women, so that all women of all races are included in the research. And then based on those learnings, based on those findings, determining what is the best care delivery for that person and for their families. And then from there, generating evidence so that we could scale that solution, particularly in addressing factors that are tied to quality of life rather than just mortality, which is what we generally do and where investments generally go. Women live longer than male counterparts generally, right, on average. So we better have a good life is the way I think of it, right? But quality of life tends to be less prioritized when it comes to drug development or other forms of intervention, and more importantly is deprioritized, right? Because it's harder to measure if you're having a good life rather than if there's mortality, yes or no. So just some opportunities for us to be aware and learn a little bit more about innovation gap that exists today.
I love that. And at Ovom Care, we're committed to R&D because for far too long, even though in vitro fertilization, IVF was based on R&D and innovation, the field has lost its way. And our mission at Ovom Care is to really bring IVF into the future. So we're actively collaborating with different entities who want to understand women's physiology and also specifically women who are of reproductive age, because we don't. And there are many things we don't understand in the physiology of pregnancy, as well as puberty. There's so many unanswered questions. And so we know that we are, as a fetus, women, when we are a fetus, before we're born, our ovaries are already formed. They're already made. So it's not just the woman individual, but also her mother and her mother's mother. And there's lots of data in animal studies, in mice in particular, that if the grandmother has suffered any injury or problem or poor diet or stress, that not only the daughter, but the granddaughter will be impacted, and potentially in the case of diet, the ovaries of the granddaughter are impacted. So that is how lasting poor health care and social determinants of health, that if it's not actually corrected, it'll have generational and intergenerational effects.
Yeah, absolutely. So it's everyone's responsibility. I think it goes back to the original point. It's everyone's responsibility to understand how and when we can invest in women's health innovations to create more resilient communities. This slide I love is from the NIH Women's Opportunity Map for 2024. I was one of the many contributors, over 200 contributors to the study. And what we've learned is that because there's such a huge market opportunity, we have to really drill down and like, what do those opportunities look like? We're talking about investment in research. We are talking about how do we improve access to appropriate care, high quality of care, regardless, so that it gives women the baseline, the opportunity to advance their education, careers, their increased household. To your point, is pretty much generational. So when we invest in women, especially the economics of it, right? Their health is likely going to have a generational impact in their children, the care for their children, closing gaps in for pediatric measures for those who are more in that field. And we're generally the primary caregivers for parents and others in our household. So it is just very important to not only identify those market opportunities, but also look at both mortality as well as disability agents so that we can really improve and advance care in the quality of life, not just the duration of life.
Absolutely. And I just wanted to comment that this slide is in the context of an American U.S. healthcare system where there's
Correct.
not universal access, as opposed to here in Europe, specifically in Portugal, where there is universal care. And because of that, things like medications, even for IVF, are reduced costs because there is that universal understanding that healthcare is a right and that everyone deserves it. And so at Ovom Care, we specifically chose Portugal, specifically chose the EU for that reason, so that we are already bringing patients, no matter where you come from, you have access to that infrastructure that's been built here in Portugal.
Yeah, thanks for adding that. That's important. So before we open it up for Q&A and discussion, I wanted to share some information on health disparities that, in addition to reproductive, which we'll get to, impact women or where women face more disadvantages, right? Primarily due to two things: access and lower effectiveness. And when we use the term access, we're looking at affordability, wait times, payer type like insurance carriers, right? But also access and understanding what the need is. When I coach women, probably the number one gap that we identify together is that they don't understand what they need, right? So if we can help women identify those things, whether it's clinical or community or lifestyle or other, then we're also improving the effectiveness of treatment and essentially the course of the pathway. So asthma is and cardiovascular diseases are probably like the top two conditions where there's the most disadvantages. Asthma in particular, when we're talking about the inhaler therapy for bronchodilators and corticosteroids, studies show that the treatment is around 20% less effective in reducing exacerbations, right, in women rather than men. And that's not only when we're talking about exacerbation, we're talking about everything from access to inhaler therapy, to education on appropriate use, to the time of use, to the adherence of the medication, and generally, there's a bunch of social factors that contribute to diminishing value, diminishing time for women to get access to those things. And then for CV or cerebrovascular diseases, one study found that despite identical technical successes in cardiac intervention between men and women, when we age adjust, essentially the cardiac events was 20% higher in women than in men. And that just tells you that there's an underlying factor that where we are not fully understanding women, and that really speaks to the lack of data and research, but also understanding what would increase adherence to protocols, adherence to whether is care plan or follow-up visits or medication that would facilitate women to be much more successful in some of these therapies that exist with these two conditions in particular.
Yeah, for a second, I was like, oh, where's my inhaler? As soon as you said asthma, I said, where's my inhaler?
Where is it?
Because I have very mild intermittent asthma. But what we don't understand in women is what happens with pregnancy. What happens, especially when you get pregnant? Asthma, a third of asthma can get worse.
Yeah.
And we understand there's a physiologic demand with pregnancy, but we also don't understand even before pregnancy, when in the menstrual cycle are you more likely to have an exacerbation? When are you more likely to have a flare? And so it's funny that I was like, ooh, I'm always after my daughter, keep your inhaler with you at all times. You never know what is going to trigger you. And now I'm like, ooh, I have to take my own advice. I think I left it in my suitcase in the room. So hopefully I have my inhaler. But this is really important. And I also want to say a caveat that in the Western world, cardiovascular disease is the leading cause of death in women, not breast cancer, cardiovascular disease.
Right.
And it's not just about diet and it's not just about exercise, but it's also about chronic stress. And we know that women often will put their children, their partner, their family ahead of themselves before they actually protect their health. And this is the sad reality, especially for minority women. And one of the other things I wanted to say about cardiovascular disease is that it can manifest during your reproductive years, early onset. So people who have preeclampsia or hypertension during pregnancy, they're more than likely already having some cardiovascular changes that's putting them at risk, as well as with diabetes and everything that contributes to cardiovascular disease. And so it's really important that people understand this, especially with conditions that we often see in a reproductive endocrinology clinic, like PCOS or polycystic ovary syndrome. Those individuals will have increased risk of having cardiovascular disease, especially if they have what we call hyperlipidemia or high levels of lipids. So it's super important that, it's almost like I tell people that reproduction highlights everything that's come, everything. So it's really important that if you have any of these diagnoses, like preeclampsia or hypertension or gestational diabetes, that it's not like, oh, I just had it while I was pregnant. It's really important that every single person who suffers from those conditions during pregnancy have follow-up, because it can lead to long-term sequelae. So we're going to go on to the next slide.
Yes. And it speaks to exactly what you said, Lynae, right? And what we've been talking about. So when I say, we want to prioritize diseases that impact quality of life, what we're not saying is, let's get rid of, let's put aside cancer, right? We're not saying that. But we want to recognize that there are other possibilities and opportunities to advance research in other areas as well. And it includes things like PCOS and premenstrual syndrome and menopause, and endometriosis. All of those conditions occur with such frequency, and they have such a gross delay in diagnoses that it just tells you there's an opportunity there, not only to use AI solutions, which is one of the top applications, and keep me honest, but that's my understanding. The top applications, especially in women's health, is to help use the data and the biometrics for early detection. Because one of the things that, again, when we coach women, one of the things that we hear all the time is like, I don't really have the time and space or even sleep sometimes to understand when my body's talking to me and I feel off, or I've been bleeding for 38 days, but you know what? I've gotten around to that, right? Women are very good at kind of adjusting and masking because they need to keep moving and not addressing some of the things that clearly raises a red flag. And the US, we're very well known because we can't access our doctor in a timely fashion. I mean, I know from my own experience, I've had to wait easily 2 months for an appointment for something that's actually feels urgent, like uncontrolled bleeding, right? And in the meantime, you access a blog or, oh dear, you Google it, right? And you find yourself in a rabbit hole of misinformation of other people who are suffering from the same thing. They send each other pictures, and now all of a sudden you're in a community of a bunch of people who are are just using misinformation or giving advice to one another based on their own personal experience.
Right.
And we build community as a survival mechanism, unfortunately. But
Right.
the ideal thing is that you work with your provider, with a care team who can guide you in some of those steps. So I'm particularly interested in even hearing from you because, one example that's shown in this study on this slide is that, for instance, with postpartum hemorrhage is a preventable cause of maternity mortality.
Absolutely.
But then there's only been two meds in the past 30 years that really have been released and properly used and studied.
Yeah,
And
misoprostol, methadone.
right.
Yeah.
So
Those are the two.
it makes you wonder, like that is a serious condition with some serious symptoms. And yet, we see very little advancement in those areas. Of course, we've seen advancements in things like cancer and other things, which are also important, but these are quality of life. And I think they honored a space and time, just like anything else.
Yeah, I mean, I want to take a moment. I mean, I went into women's health because I saw a woman when I was in Mali as a Fulbright in the Republic of Mali in West Africa. I saw a woman die in front of my eyes from postpartum hemorrhage.
Right.
And, it's preventable. It's preventable. Many
Absolutely.
things in women's health is preventable. And I want to go back to a point that you made is that it's preventable with data. And
Right.
how do we get data? Well, we're all interacting with some type of tracking modality. I've got my watch on. Other people have an Oura ring on. Other people have
Right.
period trackers.
Right.
You're able to maybe pick up when you see or detect something because you're tracking. And that data really needs to be analyzed. And this is what our goal is at Ovum, is to take that data from wearable devices, take the data that people are tracking, and actually start to see patterns and trends that can train AI models, not based on one homogeneous data set, but a diverse data set with many different people so that we can start to see, oh, these people who have this track data might be at risk for endometriosis. These people who have this track data might be at risk for endometrial cancer. It's not been addressed on a wide scale. And at least what we are trying to do is to take data and be able to tell people in the future, you might want to consider freezing your eggs because there could be a poor quality or a poor egg quality issue. Or you might consider, trying to conceive earlier because we think that you might have a biomarker for ovarian insufficiency. And I can't say how often people say, I didn't know, no one told me. By the time I realized there was a problem, it was too late, or I didn't have the success that I wanted, or I didn't have the kids that I planned to have. And it's really about having also a discussion with your healthcare provider. You said, if you have a problem, you have difficulty accessing your healthcare provider. But what about preventive care? What about talking about your reproductive lifespan, which starts when you go through puberty, when you have that first menstrual cycle? Many young adolescent girls do not have a talk to them. What do you want in your life? How many children do you want? When do you want to have them? Do you not want to have children? And at Ovum Care, we're really committed to reproductive justice so that people can really start to think, okay, what do I want? And not what is expected, but what do I want? And that way you can make, enhanced decisions also with data. Because if, I had a patient who was diagnosed with Turner syndrome, and her pediatrician made the diagnosis very early and counseled her, and she was able to make decision and have agency over her healthcare. And that is really the importance of data. And AI comes in because we can train the data based on diverse models. And this is how we can create the future of healthcare, especially when it comes to IVF.
Absolutely. And it's important as we have these conversations that we help address what else is in the minds of these women, young women, because without addressing their elephants in the room, honestly, it's hard to have a conversation about healthcare and what they want in life when they're still finding themselves, right? Or anchored on old belief systems and cultural belief systems that they hold strong. Some of these questions are pretty taboo. I would have never even thought of asking my mother any of these questions at when I was 15, 16 years old,
Not in
because
my
it would
culture
be,
either.
right, because it was like, why are you even thinking about these things?
Right.
And it would have been just tossed away. So we also need to consider those cultural nuances. And one of the things that we aim to do really, really well at AGIS is exactly that, is connecting to like, where are you, your experiences, and then by design, how do we connect with you? Because that's important in order to move forward. And then a perfect segue to that is, also understanding what's the top of the crop, right? When it comes to reducing health disparities with women, and we're talking from a financial perspective here, right? We're talking about two of the top four global conditions, which is one is PMS, depression, migraine, and then there's other gynecological conditions that you see here, and like the ones we've mentioned, like PCOS. All of those are not only important from a reduction in severity perspective, but really detrimental to a person's life easily, right? Because it impacts lifestyle. So which means if we were to impact those different conditions, now we're making a socioeconomic and healthcare impact, because that's how powerful women are in when influencing generations, changes in healthcare trends, and closing gaps in care for their families. We take care of women, we take care of the family. That's just how it's by default designed.
Absolutely. And we have a collaborator at Ovum who is trying to understand when is the age of menopause in individuals based on data. And it's so sad that it's 2025 and we can't predict when someone's going to go into menopause, which changes risk factors for things like cardiovascular health and a risk of myocardial infarction. So we should be able to do that. And this is what we're committed to doing. We want to work with everyone who wants to collaborate with us to be able to find out these really pressing questions, because menopause is not just your period stopping. It is a physiological process. And it differs from woman to woman. And only with track data. We have other collaborators we're hoping that will come on board who have kits where they can actually try to start to see the changes, and people can track and say, oh yeah, my periods have now gotten shorter. Oh yeah, and now I realize, my bleeding is lighter, or it's more erratic. Those are the types of things that, individuals can start to track, and we can amass data so that we can predict when people will go through menopause, because then it might help you to figure out when you want to have children, if you want to have children.
If you want to have children,
exactly.
Absolutely. And things like sleep patterns and mood changes also have been found to be highly connected to bleeding, right? And that it's all influential, and it's not always, the primary indicator is not always age, right?
That's right.
And that's going to be key, I think, in future research.
Absolutely. Age is relative. We have a collaboration and research project with Lynae, and we are looking at biological age as opposed to chronological age, because just because you're 40 something doesn't mean your ovaries act like they're 40.
Much, actually. Yeah.
Exactly. So let's talk about some barriers to healthcare, especially for women of color.
Yeah, for women of color, we focus a lot today on women in general, right? And I think the social factors are the primary influencers of why it impacts or worsens health outcomes for women of color. I'm going to walk you through some examples shortly, but I think the key punchline here is, what do we do about it, and what does it look like? So inequalities exist throughout the full pathway of care across the lifespan. And I just want to emphasize that it's not just childbearing years. It's not when you're older. It's everyone. And the research is lacking across the spectrum. There are 4 key components where we see the greatest inequities or inequalities and inequalities. One is in the awareness and prevention of it, talking about it. We just spoke about it. Accessibility, affordability of care, especially in the US, there's variance. Literally, if you live across a bridge or if you live across a highway, it is a key determinant of how accessible care is to you. That is just a fact of life here. Timely diagnoses. In looking at different conditions, women, in 700 conditions, women are likelier to have a diagnosis much later than men. So understanding why that is. And then the choice of treatment. Sometimes women are given certain treatments because there's some assumptions. And that even happens like in orthopedic surgery all the time, where certain options or treatment plans are given to women because it assumes that they care for others at home, and mobility might be an issue, for instance, right? So it just tells you that even doctors have been conditioned to just give options that they feel are lead to the greatest success based on preconceived notions that perhaps they have kids at home, that they care for their parents, that perhaps they
Right.
don't have enough help. And
Right.
that's often seen, especially in the Medicaid population in the US, because of the social economic gaps that we see.
Yeah, and speaking of Medicaid, if you've joined and you're not familiar with Medicaid, Medicaid is our public health
Public health.
insurance, but you have to qualify by being a certain percentage under the poverty line. So often Medicaid recipients, I would say, have great universal care, but it really depends on where they are. And if you're in a large city, you have access to university hospitals and clinics. But if you're in the middle of nowhere, which is a lot of the
A lot
US,
of the US.
in a lot of the US, then it can be very difficult to access care. So very different than a European country like Portugal, where again, access is present, and the training of physicians is rigorous, but also affordable to become a physician. So in the US, of course, most medical schools, you have to pay an extraordinary amount, and then you're in a lot of debt. And then when you're out of medical school, you choose where you want to go based on, often paying back that debt. That's not the case here in the EU.
Right, right.
So now we're talking about reproduction, my favorite.
I know this is right up your alley. When we looked at the data and we looked at where are the greatest gaps, and this is universal data, right? This is global data. We're looking at infertility. Black women, especially in the U.S., are most likely to experience infertility than white counterparts. Contraceptives, access to contraceptives, and you all know the Bill Gates Foundation has been for years focused very much on this, and it's dear and close to my heart because it just changes the life of women across the globe when we're investing in things like this, and in giving them the ability to have some form of agency of when and if they want to conceive. Sexually transmitted infections also impact women of color. Specifically, we see disparities in infection transmission. A lot of it is on awareness, use of tools, but also there's a taboo, again, the ability to have open, authentic discussions with partners, with providers on options that work for their lifestyle lacks oftentimes. And then lastly, but not least, reproductive cancers. Women of color obviously experience a much greater severity, but also diagnosed at much later stages where mortality, like ovarian, which is the top one, generally takes away many of our loved ones, unfortunately, because either signs and symptoms are not identified early on, the diagnosis is not identified early on, and there's just less options at that stage when generally is diagnosed at stage 3 or 4.
Absolutely. I maybe want to pause and talk a little bit about infertility and the minority population. It's when you look at minorities across the board in the United States, when we look at Black women or women of African descent, when we look at Latino women, when we think of women who are Native American, all of us have higher rates of infertility compared to white women. And even when you adjust for things like education and access, there are still poorer outcomes. The live birth rates tend to be lower. And access or early referral in women of color is often reduced. And there is a thought that part of that has to do with what we call medical racism, where a lot of medical students are trained that Black women and other minorities need contraception instead of practicing reproductive justice and asking people, would you like to become pregnant in the next 12 months, which is a actual public health, one key question that people should be asking at every interaction with people. Would you like to become pregnant, or would you like to not become pregnant? And so what happens is that a lot of people who might be suffering with infertility, which means that they are not able to conceive within 12 months of unprotected intercourse if they are less than 35. And if they're over 35, it's just 6 months of not being able to conceive with unprotected intercourse. And of course, we also know communities, LGBTQIA communities, where they will need assisted human reproduction. But especially in minority communities, they're not often referred early enough. So by the time they get to a specialist, such as my colleagues and myself, they have wasted precious years. And even though age is still just a number, a chronological number, there's I think a plethora of data that age is a predictor of your IVF outcome success.
Absolutely.
And so this is a really, really important point. And so we talked a little bit about Medicaid just a couple minutes ago. Medicaid does not fund fertility care. And even though the majority of people who actually are beneficiaries of Medicaid are white women, it's disproportionately higher for Black women and women of color to actually have Medicaid. Even though we're a minority, we're overrepresented in the Medicaid population for the status that we have in terms of our percentage in the US. And Medicaid does not cover evaluation. Title X is starting to now cover evaluation. So Title X typically is family planning for contraceptive access. And I really like how Title X is trying to come from a more reproductive justice lens when talking to people. And I think that they are still training a lot of their staff and members of their community to now screen for infertility. But then what? Because a lot of their population can't afford fertility care. And that's what we want to change at Ovum Care, so that anyone and everyone and everybody who wants to have a child can. And just talking about sexually transmitted infections, I think there's a lack of awareness how some of these infections, like gonorrhea and chlamydia, which can lead to PID or scarring in the tubes, can potentially cause your tubes to have a blockage and cause tubal factor infertility, which then requires you to have IVF.
Right.
Yeah.
Right. And this is why it's so important. The journey leading. So the family planning, the discussion, the plan itself is so important.
Yeah.
But the path leading to that is so important, because the earlier you can define on your own terms, your lifestyle, the options, creating a healthy environment so you increase your numbers, right?
Mm-hmm.
And provides you with greater options of how you'd like to create or recreate a family, however that looks like for you.
That's right. And what we also know is that, when women suffer from any cancer, not just reproductive cancers, women of color are more likely to have earlier, more aggressive onset for many cancers, including breast cancer, but they're often not offered fertility preservation, which is, beyond sad, because many people don't realize that the treatment will then potentially damage their ovaries and damage their ability to become pregnant with their own gametes or their own eggs.
Right.
Yeah. So if you just joined, we're happy you're here. Feel free to write in your questions. We're going to, I think, go over this slide, and then we're going to talk again about the work that AIS is doing.
Yeah, no, absolutely. And so we'll wrap up with a little bit more data, and also this is just, again, to raise awareness for yourselves on questions to ask, why it matters. Why do you matter? Cancer screenings, breast cancer screenings specifically, continues to disproportionately affect women of color, mainly because we talked about early on, if you just joined, racism, discrimination as a barrier for the screening, but there's also much higher leading rates of cancer-related death in our population because of those social factors, because of lack of access, early detection, treatment options, and then more importantly, there's lifestyle factors, especially that are highly sensitive and influential when it comes to cancer. Access to affordable healthcare. When we're talking about affordable healthcare, we're primarily focusing on those especially covered by federal health plans in the U.S., including Medicaid or Medicare, and the services that these lines provide, but also commercial payers, right? There's still a very high out-of-pocket cost that often our families, our friends can't afford. And oftentimes IVF, to your point, is the only option, depending on what their trajectory has been. And it's important for us to identify what are those gaps and set pathways on how, regardless of coverage, how can you still meet your health outcomes, your health goals? And that is something that you want to work with a provider. And I'll talk more about how we do that at HIS, because it is very holistic. And unfortunately, the doctor oftentimes can do all those different things, right? And also help you navigate. So it's important to seek support where it's much needed. And then the third piece that I wanted to touch on was the gender and racial ethnic biases that exist. Lynae briefly touched upon it, right? But I wanted to list some of the classic examples. Oftentimes, women of color, when presented with pain, for instance, the pain scale is totally off. They often seen as, oh, it's not that much pain on the pain scale. So treatments, things like PICOs oftentimes are overlooked because it's not that serious, or even worse, women ourselves oftentimes like, oh, we don't take it as seriously because we've been conditioned to just keep going and not really reinforcing the fact of how we're really truly feeling. Pain symptoms, chronic illnesses, diseases like the one we talked about, like cardiovascular, autoimmune diseases, heart diseases, much more prone to suffer from those conditions without the appropriate treatment. And then lastly, specifically in the reproductive health segment, ovarian cysts, endometriosis, uterine fibroids, something to be in the lookout. If you're a consumer, if you're a woman who's wondering, okay, how do I get ahead of this? These are some of the questions, some of the topics that you want to talk to your provider, to your care team about, so that you are aware also of like, what does it look like? Because many of us are living and walking with these conditions and not knowing that that's what we have, and we're not asking the appropriate questions. So just something to think about, because it is very much embedded and baked and integrated into our healthcare system to overlook some of these things, especially if you're a woman of color.
Absolutely. And especially when it comes to fibroids, women of African descent are more likely. Fibroids are fairly common. 70 to 80% of women have fibroids, but
Correct.
women of African descent are more likely to have larger and more aggressive fibroids. And so oftentimes people are confronted, oh, I have to have a myomectomy. I have to have these fibroids removed because I'm having severe pain or heavy bleeding. And no one is talking about, well, what happens if there has to be a hysterectomy, because that's always a risk when you go for a myomectomy to remove uterine fibroids, especially if they're large. So really, knowing, do you have fibroids early on and watching them is super important, because in case you want to use your uterus to carry a child, that's really important information. And especially being aware of that is important. I've had a lot of patients say to me, no one said that this could be an issue and that I would have to have, a major surgery to remove the fibroids, 5 years ago when I realized that I had the fibroids. So I think we are wrapping up. We're going to talk about AIS. I think this is the last slide, and then we're going to talk about AIS.
Yeah, no, for sure. So when we talk about prioritizing, I always want to leave the audience with, what can I do? How can I be part of the solution? What questions to ask? One last tidbit here. How do we prioritize, and what conditions should we be prioritizing? Because we face many conditions as women who are that are not necessarily like leading or trying to impede mortality, we really need to focus on what are creating barriers to our well-being or creating more disability. So just kind of keep in mind, life should not be that hard, okay? That's at the most basic level. You should feel relatively okay, well, every single day. And if you're not hitting that, you should be asking questions. Don't live with like, I'm okay. You should be thriving to say, I am doing well. Okay. If something's off, you should be able to mind. So working on strategies to really connect that mind body is going to be important. And then reducing those stressors, which, as we've learned, is a key underlying factor to so many conditions that oftentimes is overwritten, because in our society, we focus so much more on productivity rather than cultivating our own creativity and our own well-being. And then when we're talking about chronic conditions like dementia or different cancers, we know that it impacts us much more disproportionately than anyone else. So we want to make sure that preventive screenings, identifying or the space to really have timely follow-ups for care, medication adherence are going to be toward your advantage. Making sure that you obtain information from the right sources is going to be the biggest win of your life, because it will save your life, but also improve the quality of it. And then being aware of what conditions, women-specific conditions like ovarian cancer, specifically impact us, and how can you prevent it? And how does it connect to your reproductive health, right? Ultimately, everything that you focus on in life should be geared or connected toward what is the goal that you have in mind. What's the most important thing to you? Because if family building is important to you and is something that you're looking forward to, then your goals and the path leading to that, you need to be aware of what steps you need to make or take or design to get you to that place, and obviously work with the right team that will get you there. So I'm going to pause there. There's so much more to this, but I feel like that those are some of the major touch points for around prioritizing quality of life. And then HIS. I shared with you the unfortunate root of how HIS was developed, designed, and created, but it was, as you all know, and you've probably gathered from me, I'm very much honoring all of our experiences. And I feel like all of our experiences are part of our purpose and why we're here. And for us, for my husband and I, we experienced 3 recurring miscarriages back to back in 2020 before having our 3 very healthy children. Up to this date is still unspecified. We just don't know why they happened. We thought we were fairly healthy. And then we said, you know what? There should be an organization that looks at women holistically, but focusing on what focuses in women, what focuses resources that focus on what mostly is influence or impacting women, and what impacts different women, right? You need to ask those questions. So these are some of the complexities and conditions that we focus on today when we talk to patients and consumers alike. If we were to work with health plans or we work with health systems, we help identify women who are much more at higher risk of gaps in care, including some of the conditions that are listed here. And then we engage them to coach them, right? We coach them to prioritize not only the different areas of their lives that would they see as a barrier to reaching their health outcome, but more importantly, the resources that we provide us and the guidance are also non-clinical, right? Because if you're able to understand what's most important to you, then naturally you're going to gravitate towards wanting to be healthy, wanting to feel good. Because when you feel good, other things manifest in a way that are really helpful to you. So when we formed a partnership with Ovom Care, we knew it was the right fit because that mission was very much in alignment. And we very much believe that you could still have a very healthy life and have a very healthy pregnancy and maternal outcomes, and you don't need to compromise your well-being. And that was really important to us. So now we've been in development for now 3 years, and we aim to continue supporting women across the globe.
Thank you so much. And thank you so much for being here. We have questions from our audience. I'm going to go through this slide. We can also post this slide. It'll be on our YouTube and also be on your social channels at AIS. So we are excited to talk about a little bit more. I'm going to go to Q&A. There we go. Your questions. We've been talking a lot now. So I'd love to see if you have any questions. So you can go to the Q&A. You can ask a question. They're anonymous. So we are going to look now to see if we have any questions. And I think we do. I saw some pop up, and let's see. So we have one question. Are there any examples of how AI could be applied to address minority healthcare disparities?
Yeah, I mean, there's yeah. I mean, we could frame it. I think AI can help really aggregate large volumes of data and really create a nice baseline where at least providers and care teams can have a jump start on understanding what are the areas of opportunity. Some of the ones that we discussed, obviously, like what are the top opportunities in training, in education, in detection of specific diseases, in the treatment of specific diseases. And I think where we fall short today, where we hope that AI can have a greater influence, is how do we properly engage consumers and patients so that this speaks to them? Because there are solutions. There's a ton of solutions out there, but we need to find a way, and that's where AGIS kicks in, is one, how do we connect to meet you where you're at, literally, right?
Mhm,
Because
mhm,
we can tell you, we can give you all the solutions in the world, but if you're not ready to make certain changes, you're just not going to change certain
mhm,
ways, right? And
mhm,
the alternatives will kick in. And
mhm.
then two, how do we then scale that? How do
Yeah.
we understand and ask the right questions across different consumer types, considering race, ethnicity as key factors to
Mhm.
then understand, oh, these specific groups better engage this way, and therefore we have better ways of formulating plans for them. I mean, the big tech giants know how to do this really well, right?
Mhm.
When you're shopping in Amazon, they know
They
exactly
know.
what you're doing. So how do we then replicate that type of behavior in economics when it comes to healthcare without crazy wait times and regardless of where you live or how much you can
Mhm.
afford?
Yeah, and tech is really the solution for that. We have published data, but those studies, we're excited if we have 1,000 people or 500 people in a women's health study. We need data in the millions, and
Yeah.
it's already there. People, like I said, are tracking. They're using wearables. There's data that could be already used. And at Ovum, we have an AI and data team that's committed to partnering with our collaborators to take that data and look for trends and patterns.
Right.
And that data can reach more people than just a single center or even a multi-center study where
Right.
if 13% of people are minority, people are very happy, but that doesn't necessarily represent everyone everywhere. And so technology is sort of that link in that gap, and we can take what we know from published data and also what we know from track data and wearable data and
Right.
responses to questionnaires that are online and be able to train models that can actually serve us. So going on to the next question, what can men and non-binary individuals do to support reproductive health initiatives?
There's several things. I think raising awareness, understanding is the first step. We all, regardless of how we identify, is our moral duty to understand each other. That's how we respect each other. That's how we honor each other. And we can ask questions, we can educate, we can raise awareness that way. And we did a lot of that here, but a lot of it you'll do in your individual communities. The second thing is around advocacy, right? When you see a gap, like say something, address it. Don't stay in the quiet or in the unknown. Act from a place of knowing. Don't act from a place of fear or not knowing, because that's where misinformation comes from, and then it gets spread out. And then support. We are all the children of someone. We all have mothers, whether they're around or not around, or relationship is there or not there. So we honor the fact that we're here. So how do we then support other women, other patients, really stand for their own well-being? How do we support women so that they could feel cared for, so that they can then care for themselves? Because it is a cycle that I think is going to be super important. And then lastly, but not the least, is for those who are in healthcare or in community-based organizations who are listening, how are you working to prioritize some of these opportunities that we talked about today? How do you intend to invest in some of those innovations? And then how do you formulate those partnerships so that you can continue scaling this type of work? Because that's going to be important. Investment in R&D and research and development, investment in innovations is really what's going to set the future for the next 10 years at least.
And I think that leads perfectly to the next question. What policy changes are needed to improve access for women's reproductive health care?
So there's several, and I know some of us are concerned, right, with some of the executive orders that have been issued recently, but there's some light. So the first policy that we need to really think about is how are we exchanging and sharing data, so
Mm,
that see the full view, the full spectrum of resources and gaps and opportunities, so that then we can leverage and utilize some of the technology and AI that you talked about, Lynae.
mhm,
The second is around how do we protect women, right?
right.
Because we talk a lot about what's at risk, and we talked about things like abortion in the past, and
Yes.
the level of agency that women have over their bodies, and those are all very controversial topics. But the reality is, if we don't openly talk about these things and have women be part of those solutions, right, and what their needs are and what they
Mhm,
want,
mhm,
unfortunately, we won't design a solution that works for women. So more advocacy in those controversial topics is going to be key, even if it's scary. But if we don't push forward, we'll continue going backwards, unfortunately.
Yeah, we've lost a lot of ground, and I just want to say rest in peace to Cecile Richards
Yep.
from Planned Parenthood, who was at the leadership for many years, who passed away earlier this month. And I think that, policy is so very important, and we can only vote so many days and, in so many years, but we can every day call our elected leaders. We can every day protest measures that take away from our reproductive health. And part of the reason that at Ovum Care we chose Portugal is because Portugal's policies are fairly open-minded when it comes to reproduction. And I think that around the world we are seeing, not just in the US, but also countries like Italy, already in the DACH region, so Germany, Switzerland, and also Austria, where things are very, very conservative and people are making your decisions for you about your body. So every day we can actually be our own advocates and advocates for our community. So we have one final question. We'll stop here. It's a question about miscarriage and also age. So, Vanessa, you started out sharing you had 3 miscarriages back to back. Did anyone ever tell you as you age that your miscarriage rate increases? Is that something that your OBGYN mentioned to you, or your nurse midwife, or anyone ever said that when you try to get pregnant at later ages, over the age of 35, your risk of miscarriage goes up exponentially? Did anyone ever say that?
Not necessarily called it out leading to it. No, I mean, we heard it in the midst of the chaos as we were experiencing them. And we talked to IVF providers, just seeking options and understanding what if we did have an issue or problem that we could address. And that's when it was brought up, right? What the moral of the story is that it wasn't brought up earlier on where options or awareness could have been brought in, right? And ultimately we because we're not sure what caused it, other than age being a risk factor. It could have been progesterone or estrogen levels, right? Which then that was part of the care plan when I was pregnant, just to increase the chances of keeping the pregnancy to term. And the reality is, if you don't seek the right care with the right providers and having options, you're unable to then synthesize, okay, what information feels right to me and what am I going to move forward with? Because that's also a hard thing. It's not only about the information that you hear, but like, who do you trust who's giving you this information, and then you're going to follow that
right
program.
And it shouldn't be Dr. Google. It shouldn't be chats in different fora, because you have that information has not been reviewed. You can't check the accuracy or the data behind that information. And so that's why it's really important to us at Ovum Care, through our Ovum app, which we'll be releasing soon. We'll have a library of information. And I'm excited about our collaboration for that as well, our content collaboration. So this has been a real pleasure, a real treat. Thank you, Vanessa Guzman. Thank you for creating AIS and creating space for people and women around the globe who absolutely need the coaching and the support. So thank you for being with us. And if you joined, thank you so much for joining us. There will be a recording of this webinar on our YouTube, and you can follow us on all of our social media channels at Ovum Care, OVOM CARE. And we hope to see you for the next webinar, or at one of our clinics in Portugal, or online, where we also provide care. So thank you so much.
Thank you so much for having me. Be well, everyone.